All right. So I am Philip Dayley. Just kind of brief about me. So I'm originally from Southeast Idaho, born and raised down in Pocatello. Went to University of Utah for undergrad, and then kind of toured the world through medical education. I did medical school down in Alabama, and then did residency in OB-GYN up in Ohio. During my residency, I developed an interest in addiction medicine and treating specifically women and pregnant patients with substance use disorders. So decided to stay around and do an addiction medicine fellowship at the same place that I did my residency. It was kind of a unique area. It was up in Akron, Ohio, which, if you have been doing addiction treatment for very long, you know that is the founding place of AA. So we had a large volume for treatment of alcohol use disorder, because we'd have people that would kind of do pilgrimages almost to come out and do detox from that. It was also at the unfortunate location near the epicenter of the fentanyl epidemic. And so we had a large amount of fentanyl use disorder in our patient population as well. So was a good place to do some training. And then I decided, hey, it's time to get back closer to home where my family is. And so now I am out in Nampa, practicing with St. Luke's, doing primarily OB-GYN, but working on building up a patient population as well, helping out with treatment of substance use disorder in pregnancy and in the postpartum period. So kind of building that up at this point. All right. I will give full disclosure that I have a tendency to run long. So I made a conscious effort to make short slides. So I may run short today. We'll see how this goes. I have no financial disclosures to make at all. There may be some off-label usage of medications discussed during today's presentation. That's pretty par for the course as far as addiction medicine goes. We like to use lots of medications, and not necessarily in the ways that they are designed to be used or recommended to be used, but we do use those off-label for some treatment. All right, we'll go to the next slide and go over some learning objectives. I like to start off any presentation that I do just kind of rehashing the things that we should all know, talking about the chronic disease model of addiction and kind of how that shift took place. I think it's a good framework to remember in how we're interacting with our patients, how we're using non-stigmatizing terms with our patients. Next, we're going to go over some basic treatment of opiate use disorder, specifically in pregnancy, medications that we use for that, and modalities for that. And then we'll talk a little bit on the physiology changes that occur during pregnancy that can affect the metabolism of the medications we're using, and how we may need to adjust our dosages a little bit for our pregnant patients as well. All right, we'll go to the next slide. Again, just talking through the chronic disease model. I think this is useful when you are addressing your patients that have a substance use disorder. And really, it's a reframing of how we've viewed substance use disorders. This isn't a moral failure or a weakness or anything like that. It really is viewed as a chronic treatable disease. And the way I like to discuss this with my patients is it's no different than something such as diabetes, where it's a spectrum. For some patients, they may be able to manage diabetes with diet and exercise. For some, they may require medication. That medication may be long-term, it may be short-term. That gives us kind of a good framework and a way to reflect on that with our patients, where substance use disorders are a spectrum. Some patients are able to go through treatment utilizing counseling and IOP and coming up with coping strategies. Some need medications, and those medications may be short-term or long-term, depending on their specific circumstances. Genetic predisposition exists, just like diabetes, estimated to be between 40 and 60%. And it just gives us that non-judgmental way of discussing a substance use disorder, making sure that we try and avoid stigmatizing terms with our patients. So, instead of saying clean versus dirty, we try and use negative or positive. And these are patients or people with substance use disorders, and treating and addressing them as such, instead of using terms like addict or junkie or those sort of things. Now, the one asterisk I will put on there is, in my practice, I find it's useful to be able to use both, because some patients will use stigmatizing terms to identify identify themselves. I find that as a good discussion point with them where we can go over medical terminology a little bit, but it's helpful to have kind of those same, I don't know, street terms, as it were, to discuss with your patients. I can't count how many times I've talked with patients about IV drug use and they don't know what IV means. And so then we talk about IV versus shooting, et cetera. So having access to the different terms, I think, is important. Little picture there just to remind us about our different phases: binge intoxication, withdrawal, and then preoccupation, the addiction cycle. We can go ahead and jump to the next slide. Jumping into pregnancy and management of such. The recommendations from the major medical organizations and societies in America are for universal substance use screening in pregnancy. And I like to emphasize this point. Both ACOG and ASAM, those are the American College of OBGYNs and the American Society for Addiction Medicine, obviously, recommend universal screening, but screening does not equate to a toxicology test. And I think that's important to differentiate, that we're looking to screen patients for substance use disorders, but not necessarily knee-jerk ordering urine toxicology screens on our patients. Really, we want to use some validated tool. The one that I've used in the past is the 5Ps, and I've put a copy of that there for you to look at. And then if they screen positive on this, that triggers a discussion with your patient. Really, why did we screen positive? And would it be helpful to get toxicology? Is that going to change our treatment or change our management? Or really, should we just use this as a good time to use our brief intervention and then get referred to care so that we can connect our patients to treatment and make sure that we're taking care of them as best we can? Go to our next slide there. This is a wordy slide, and I apologize for that. I'm not going to read through all of it, but I wanted it to be in your slides because I think this is important. This is all, these are statements that are direct quotes from the ACOG practice guidelines for substance use disorders in pregnancy. And really what it's looking at is our ethical responsibilities with our pregnant patients. When I talk with health systems about this, and I've helped devise and come up with some substance use screening criteria for several health systems now, what I talk about is the importance and the impact of urine toxicology screening. And I would argue that really there's no more impactful test that can be done on a pregnant patient than looking at urine toxicology because of the legal ramifications that get tied to that. And that's really what ACOG says, is we need to be considerate of that. And we need to have a good reason that if we're getting those screens, we need to get informed consent from our patient, let them know what a positive and a negative screen would mean, and then kind of what our responsibilities are as far as state and federal requirements for mandatory reporting, if those exist where you practice, and knowing where we need to go for that so that we can have those conversations with our patient. Jump to our next slide. Why is all of this important? And this is the slide that I think everyone has seen in the past. Anyone that's been around treatment of substance use disorders is going to see this big ramp up of substance use disorder. And really the data for pregnant patients mirrors that in the general population. So we've seen an increase in maternal opioid use. It's gone up fivefold from 2000 to 2009. We're seeing an increase in NAS, which is neonatal abstinence syndrome. We'll jump into that a little bit towards the end of the presentation, where that's increasing the number of births that require treatment. Most recent data in 2017, about 8.2 per thousand deliveries were affected specifically by opiate use disorder. So this is fairly prevalent, and it's probably, like all addiction disorders, underreported because we don't screen for it very well. And oftentimes our patients don't want to be kind of discovered as having one of these substance use disorders, again, because of the fear of legal ramifications. Next slide. All right. So what are the excuse me, treatment guidelines for opiate use disorder in pregnancy? And really, it comes down to using an opioid agonist for pharmacotherapy. Medically supervised withdrawal is not recommended in pregnancy. And I've got another slide that'll delve into that a little bit more, but really it's been shown to lead to things like increased relapse rates, which would lead to worse outcomes, or fetal withdrawal in utero, which can also lead to worse outcomes, things like fetal demise, even in worst case with that. So medically supervised withdrawal, definitely not recommended. Really, it's using some form of opioid agonist or partial agonist. So buprenorphine versus methadone. I'll touch briefly on naltrexone. There is some data coming out on that nationwide, but it's very early and primarily case studies. There are some practitioners that will utilize naltrexone, especially if a patient is stable on that prior to becoming pregnant. But you have to counsel your patients. There's not a lot of data on that and long-term outcomes from that. Little chart there just to look at neonatal and maternal outcomes. It's a little small, but shows risk of NAS between a full agonist and a partial agonist. And it's really what you would expect, right? So if you're giving a patient that's a full opioid agonist, it's going to have a little bit of a higher risk of things like neonatal abstinence syndrome and withdrawal than a partial agonist. And the data kind of pairs out on that. All right, next slide. Methadone. So just a reminder, physiology of methadone and kind of how it's dispensed. Full disclosure, I rotated through methadone clinics during my addiction medicine fellowship, but have never since then have not really prescribed methadone other than continuation for patients that are inpatient and being managed through a treatment facility outside of the hospital. It is a full opioid agonist. It's dispensed on a daily basis, though some patients will earn take-home privileges. Remember your 30-40 rule as far as that goes, 30 milligrams for your initial dose, no more than 40 on the first day. Typical dosages for these and where I trained would be in the 80 to 120 milligram per day. Now, I know that that seems on the low end, and in pregnancy, that may be on the low end because of the physiology changes during pregnancy, especially as blood volume increases, metabolism increases as we approach the third trimester. A lot of patients will need adjustments and perhaps increases in their dose. There is some data now coming out that says split dosing really probably should be the standard for our pregnant patients because of the way that that dosage curve falls off in pregnancy. Think of these as almost like a rapid metabolizer patient on methadone, where you can do peaks and troughs, but we already know what the peaks and troughs are going to be. So, because of that, some states, such as Washington, have pushed for split dosing being the standard of care, where patients can dose in the morning and in the evening in order to keep a more steady state of that methadone and avoid fetal withdrawal and maternal withdrawal, which again decreases our relapse risk. You can have withdrawal symptoms from methadone if undertreated, especially as we're kind of increasing dosage to get to an adequate level of care. They're similar to any withdrawal symptom from an opioid. There are some pharmacokinetic interactions for this. It can prolong QTC, so needing an EKG to make sure you've got patients that are appropriate candidates for methadone dosage. And then, like we talked about, a little bit of an increased risk in NAS when compared to a partial agonist. But the overall incidence of NAS, and I'll echo this again when we talk about buprenorphine, is not dose dependent. So what we don't want our patients thinking is, if I'm on more methadone or more buprenorphine, then my patient or my baby is at a bigger risk of having withdrawals after delivery. The data really doesn't support that. We've seen patients that are on relatively low dosages of something like buprenorphine, say 4 to 6 milligrams a day, that their babies have quite severe NAS. We've had patients that are on 24 to 32 milligrams and don't have any NAS. So it's really not dose dependent. And then again, with methadone being a full opioid agonist, there's no plateau in the dosage, right? The more you give, the increased effects that's going to have. Next slide. Next up is buprenorphine. This is the one that I am most familiar with in my practice. This is what I tend to use for my patients. It is a partial opioid receptor agonist. So with that comes the risk of precipitated withdrawal and kind of the funky way that we have to get patients stabilized onto buprenorphine in pregnancy. And we can talk through that. I didn't delve into the nitty gritty too much in this slideshow, but happy to chat about that afterwards if we want to go different strategies of how to get a patient stabilized onto buprenorphine, because it can be difficult, especially with patients that are on fentanyl. It's almost a square peg in a round hole situation on that. So fewer drug interactions with buprenorphine overall. You don't have to dose on a daily visit. It can be written by anyone now without, you don't need to have additional training, no X waiver, et cetera. That was all gotten rid of. Less need for dosage adjustments overall, primarily because we have less dosage amounts available. And again, it has that plateau effect. So once you hit a certain point, giving more buprenorphine is not going to have an increased effect for your patient. It's available as both a monoproduct as well as combined with naloxone. This is your trade names. I know I'm supposed to stay away from them, but Subutex versus Suboxone, as we all know. The data in pregnancy really has shifted towards Suboxone or the combination product being safe in pregnancy if taken as prescribed. And the reason I put that caveat in there is the entire reason for having the naloxone in there was to try and prevent patients from abusing or misusing the medication, melting it down, injecting it, et cetera. And so if they induce withdrawal on themselves, it's going to have the same risk of having withdrawal outside of this medication, things like fetal distress, fetal demise, et cetera. There are several long-term injectables available of buprenorphine, and the data actually looks pretty promising as far as pregnancy goes. There was a more recent study I actually found as I was preparing this presentation by one of the manufacturers. It's a small case report, but really it didn't show any increase in birth defects, miscarriage, or maternal complications when compared to the general population rate. Again, giving trade names for this was Sublocade that did this study. They did sponsor it, so we always have that going on in the back of our mind. But initially, when Sublocade was released, it had a black box warning, absolute contraindication to use in pregnancy due to one of the carrier molecules being found to be teratogenic in supraphysiologic dosages. They've gone back, they're trying to look at this again and say, no, this is most likely safe. The other long-term injectable that is available, trade name for that is Brixadi, does not carry that same warning, does not have that same carrier molecule. And so is the warning that's on that is the same that's on general buprenorphine, where it talks about risk of NAS, et cetera. So probably a little bit more data to come on that long term, but people nationwide are starting to use the long-term injectables, both outside of pregnancy, obviously, but within pregnancy as well, because of more stable state as far as physiology goes, and then decreased risk of diversion. Next slide. Medically supervised withdrawal, again, not recommended, again, because of those risks of withdrawal on the fetus, high risk of relapse, but it does happen. You will have patients that come in every now and then that will say, or I've had them come in and say, I do not want to be on any form of medication for substance use disorder. And so for those patients, you do have to counsel them extensively on risk. And really, I would encourage that if we're doing supervised withdrawal, you should be at a tertiary care center where these patients could be monitored for this. Really kind of a multidisciplinary approach, utilizing your addiction medicine colleagues, utilizing your OBGYN colleagues, even maternal fetal medicine, to come up with a plan to make sure that you're monitoring the baby well and that you're controlling mom's symptoms to kind of gradually taper both the opioid that they were on, as well as using adjunctive medications to help control symptoms that they're having. Sometimes these patients require medications such as benzodiazepines in low dosages to help with agitation and really kind of to get through that withdrawal. It can be quite difficult, especially with patients that were on substances such as fentanyl. Next slide. All right, generalized care during pregnancy. Again, this is from ACOG. You want to make sure you're screening for other substance use disorders. So I know primarily focusing on opioid use disorder, but co-use of other substances is highly common. Making sure you're screening for those, screening for your dual diagnosis patients, behavioral health conditions, and then connecting to care for those. So even something as simple as screening for tobacco use, and then you can connect them to care or go through nicotine replacement therapy, which is safe in pregnancy. So talking through them with that. When I'm looking at kind of general management of the pregnancy itself, there is theoretic risk with some of these medications that we use. So getting growth ultrasounds to make sure we're not growth restricting the baby is important. We routinely do antenatal fetal surveillance for these patients to make sure we're getting either NSTs or BPPs to make sure, again, baby's happy, healthy, and doing well. And really, just like everything in medicine, this is a team sport. It really has become that, where it's hard to be a solo practitioner that knows absolutely everything. So relying on your colleagues, considering anesthesia consults for these patients so that if they're on a medication that's going to interfere with anesthetics, do we have a pain control plan for these patients? Do we have pain control plan for patients that end up with a C-section? Especially if they're on buprenorphine, that can be a little bit more difficult to control pain. And so having anesthesia in your pocket as far as what medications can we give that avoid going down the opioid pathway if we need to, or can we give higher dose opioids? And really just kind of those consultations can be helpful. You want to make sure that your NICU and pediatrics are aware, again, because of that risk of NAS and possible need of treatment of the baby. Breastfeeding is encouraged for patients on medication for opiate use disorder. This really delves into NAS and what helps with babies that are going through that mild state of withdrawal. And I think my next slide's about that one. And then as they are coming in for labor and delivery, you want to continue their treatment. So really do not, I guess the prior way that we would do things is if they were on buprenorphine, we would consider discontinuing that for things like surgery and labor and delivery. And really the data has shown that just increases your risk of relapse. And we can continue the buprenorphine and dose a full opioid agonist over the top of it if we need to, or you can look at alternative pain pathways, things like ketamine and Toradol and those medications. Next slide. All right, neonatal abstinence syndrome. This is, in simplest terms, baby withdrawal. It's characterized by hyperactivity of the central and autonomic nervous system. So these are babies that have a difficult time feeding. They have increased irritability. They have increased crying, difficulty sleeping. And so, how do we treat that? Depending on what substance or medication the patient's on, the time frame for NAS is a little bit different. Full opioid agonists, especially those with long half-life, have a risk of NAS much longer than those that are exposed to buprenorphine. Buprenorphine tends to have a little bit more of a predictable withdrawal for these babies. And so the observation time frame may be different as far as how long you keep babies in the hospital to watch for these. One thing at my prior health system we did is we were previously watching for 7 days, and then if they were on buprenorphine, they shortened it to 5 days because we found the withdrawal actually was pretty much done by 5 days, and then we could get them home after that. We consider treatment adequate for the patient as long as they can eat, sleep, and you can calm them down. And that's really kind of the newer movement for treatment of NAS is using that eat, sleep, console method. Some places are utilizing Finnegan scoring or modified Finnegan scoring or eat, sleep, console in a combination with Finnegan scoring. I like eat, sleep, console because it's simple. Like, can baby eat? Can they sleep? And can you calm them down within 10 minutes? Then they probably don't need treatment. But it's helpful to have all of those. And again, be familiar with what your health system uses and be familiar with your NICU so that they can be aware of these patients as they're coming in. As I mentioned, breastfeeding, as long as they are stable on their medication and not using other substances, they should be encouraged to breastfeed. Breastfeeding is soothing for the baby. As I try and think about this, you've got a baby that, inside the uterus is sloshing around in this nice warm water bath, can hear mom talking, can hear, support people talking. And after delivery, it's disorienting for babies, right? For a baby without NAS, it's can be disorienting. It's cold. It's not warm. You can't see very far. You can't hear mom's heartbeat all the time. And so breastfeeding and skin to skin are really important at baseline, but even more so for patients where their baby might be going through NAS. That suckling motion is important. Breastfeeding is important. And then being skin to skin with mom so they're nice and warm, can hear the heartbeat. It's very soothing for those babies. All right, next slide. Just briefly in summary, so medication for opiate use disorder, standard of care during pregnancy, both or either methadone or buprenorphine recommended. Really, the guidelines are if they're stable on something beforehand, continue what they're stable on. We don't want to destabilize patients. Keep the medications going while they're on labor and delivery, and make sure we're screening our pregnant patients routinely and universally, again, using a screening questionnaire or standardized screening methodology at their first prenatal visit. Next slide, I think, is just my references. And that is all I have.
Phil, thank you so much. That was a great presentation. Just as a reminder, these slides are available on our website. I think Eric already put a link into the chat. But if you're looking to reference those, you can find them on our website. I would love to open it up for a few minutes for questions or thoughts. And so you can put your questions or thoughts into the chat. You can also use the raise hand feature, or you can just go ahead and unmute yourself. Brenda, I will let you go first.
First of all, thank you, Dr. Dayley. I appreciate the information, particularly surrounding methadone and Suboxone during pregnancy. I have been an employee here at Raise the Bottom for 10 and a half years, or just over 10 and a half years. Had a lot of pregnant moms come through, whether they're already pregnant when they come in and start treatment or become pregnant during treatment. And I cannot say enough positive things about the information you provided because it is so important. Unfortunately, there's still some providers or OBs in the community that have asked patients or told patients to taper off of methadone during pregnancy, which is absolutely discouraged and not recommended. Split dosing is something that we typically are looking into as soon as we find out somebody's pregnant. We still like to do a peak and trough. Some rare occasions, we have pregnant women that don't require a split dose, but I would say there's a large percent that do and end up being very successful, far more successful during pregnancy and remaining abstinent and from other illicit substances during their pregnancy with a split dose. So, and pointing out that the potential for neonatal withdrawal symptom after birth there is no correlation with the actual dose because we've had patients that have been at 15 milligrams methadone and babies spent longer time in the NICU than somebody at 140 milligrams. So thank you for that.
Absolutely. Thanks for echoing that. Yeah, I think especially that point in counseling your patients that really the most important thing is to keep them at a steady state, right? And not trying to power through or go through the withdrawal symptoms with an undertreated dose is really important.
And I know that we work really hard on, as soon as we find out somebody's pregnant, we work really hard to have them come in at least once a trimester and work with one of our providers or meet with one of our providers to ask any questions, to go over any questions they might have, and really reinforcing the importance of dose stability throughout pregnancy and the likelihood that as pregnancy progresses, methadone doses usually need to increase as well.
Yep.
So
Yep.
Thank you.
You're welcome.
Thank you, Brenda. Other questions for Phil? All right. Well, thank you so much. That was a really great presentation. Again, these slides and the recording are going to be available on our website. So Dr. Daly, great presentation. Thank you so much for being with us today.
Thank you for having me. I really appreciate the opportunity.
Yes, and the great thing about this is that you did such a great job covering what's going on during pregnancy and birth, and now we have some folks from IDHW to talk about the resources available um, during the postpartum period. So again, we're doing a little bit different today. We have kind of two mini presentations rather than a presentation and a case. So we have a couple folks with us, and you know what, Cora, why don't I turn it over to you and you can introduce your team and I will pull up slides and just let me know when you want to advance and move forward.
Sounds good. Thanks. Hi, everyone. Thanks so much for having us here today. After hearing Phil's presentation and even your questions, Brenda, I feel like this is a good fit, and I feel like there's a lot of networking opportunities here um, to help each other support the population that we're serving. So I'm really looking forward to connections we might make moving forward. But we just have a quick presentation for you guys, for you all, about our new case management service for Medicaid members who are pregnant and postpartum, and who need support managing substance use, diagnosed disorders, or undiagnosed. My name's Cora. I'm an LMSW and a clinician with the Division of Medicaid with Health and Welfare. We've got a handful of our Medicaid team members here today to help address any program related questions. But helping me present is Connie Pulley from Telegen. And Connie, I'll let you introduce yourself. Are you on here?
I am. My name is Connie, and I'm a registered nurse case manager with Telegen. And we have just started this new program in the last couple months, so we're super excited about it.
And just for some context, I didn't know this before beginning with the department, but Telegen is contracted with Health and Welfare to provide case management services for medically complex Medicaid members. And so Telegen, the care managers like Connie and her team, are the ones who are actually implementing or delivering this service. And we're good to go to the next slide, Shannon. Thank you. So I'm not going to go over all the data, but the service was created to align with the strategic goals of the department, really aimed at decreasing the number of foster youth entering the system. And it is based on evidence, that we see a majority of families who are becoming involved with the foster system are a result of untreated substance use disorders, parental substance use disorders. And then we also see that that number is growing and that children under age 1 make up a disproportionate representation of that population. So the program really aims to address those needs by working with mothers who are pregnant or up to a year postpartum. The overall objective is really to expand the telephone-based case management services to pregnant and postpartum women with identified substance use disorders or recovery needs. And next slide, please.
So, case management services for SUD and pregnancy is all telephone based. So, our patients don't need to go anywhere, and we do everything over the telephone. Basically, what we do is we coordinate care between, of course, the member, behavioral health, and the physician that's taking care of them. We connect patients to recovery supports, and also we have Magellan, who actually does behavioral health, and we do refer to them there as well. Case management services can last anywhere up to a year postpartum, but a lot of that just depends on what's going on and what they need. Next slide, please. Eligibility. So, of course, pregnant or postpartum women, any diagnosed or undiagnosed substance use disorder, and they must be primary Idaho Medicaid. Next. slide. So the way it works is you guys would send a referral or whomever, a member can refer herself, caregiver, or a provider can refer. And actually, there will be stuff at the end, information at the end of this presentation to let you know how to do that. Once we receive the referral, we will actually establish if the member meets eligibility by having primary Medicaid. And then we will actually talk to them and see if they would like to enroll in case management services after we explain to them everything that we can provide. Intelligent case managers provide ongoing case management support throughout the pregnancy and postpartum, as we said before. And also, we will discharge, number one, when they're ready to discharge or they do not want to be followed anymore, or we just hang on to them if they feel comfortable with that. Next slide, please.
So this is a newer program, and really, on the strategic goals page, I'd kind of listed out the objectives in terms of, goals for the number of referrals and the number of engagements for the program. Where we have a lot of room for growth with those numbers, and that's due to these engagement barriers. The first is, getting this information in all of your hands and, OB providers, pediatricians, mental health providers, anybody who has existing relationships with members who are experiencing substance use disorder. And another barrier that we assume is attributing to, needing assistance with getting referrals for this program, or just the nature um, of the population, the vulnerability aspect. So it's asking a lot to ask somebody that you have a rapport with to send a referral to somebody who is associated with maybe the department or health and welfare, and asking to send that referral and have them engage with a new provider to discuss substance use disorders. So we're really looking, like I said, to get this in the hands of providers and professionals who have existing relationship and rapport with these members. And the reason for that is so, you can address with them this last one, like potential fears of criminalization. You can really candidly talk about like what the local legislation and duty to report says, their informed consent, that it's up to them if they engage and when they choose not to engage. And so that's why we're here today, is we're trying to get this information in all your hands. So hopefully you guys can help us kind of get more referrals, or just get this information in the hands of people um, who can share the service. So so we see it providing for the population. And then next slide, please. So this is the information on how you'll send a referral. Um, Shannon, do you send out PowerPoints after presentations?
Yeah, these slides are also on our website.
Okay, perfect. So here is the Telegen email right here. So you can send Telegen an email if you have just questions that you want to brainstorm, whether it's an appropriate referral. You can call the Telegen case managers at this phone number. This QR code will take you directly to the Telegen referral PDF with information on where to send it at the bottom. You can also visit Telegen's website, and although you won't see anything specific to the service targeted towards pregnant and postpartum women, you can still refer to the medical care management services on their website directly, and they will triage and send it to who it needs to go to. And then we're also working on maybe trying to find a way to get this more public facing. It's difficult within the department, clearing all the levels of approval we need, but we are looking at getting it on Idaho 211's page, and Find Help Idaho. The navigators should know about it. Magellan should know about it. But yeah, just working right now on spreading the word and please refer, please share. And that's all. We're open to answering any questions you guys might have about the service.
And one more thing, if you don't want to send in the referral, you can call that number directly.
Cora and Connie, thank you so much. Would love to open it up for questions from our audience members or our panelists about this program.
So this is Debbie Thomas, and I'm the Chief Executive Officer of the Walker Center, and I'm on the other SUD panel. But I wanted to come and just say that, first of all, Dr. Dayley, your presentation was right on and very enlightening. And the additional resources that Telegen is going to be able to offer, so vital. I want to share one more resource that's in the community. Walker Center received a SAMHSA grant, and we are able to treat pregnant and parenting women absolutely free for a residential stay, 90 days actually of residential treatment, and then they're followed back into the community by our social workers and our techs to really reestablish those connections. We've had sober babies born. There's a woman in northern Idaho that came. We can do pregnant women. She actually named her baby Hope after she left because she was so pleased with the fact that she had a child that was not in the department's care. The other part about this SAMHSA program is that we have dollars that will also help any person who has an opioid or a stimulant use disorder. They can get the same fully funded residential followed by a year's worth of care out into the community. And it's just a resource that we then can network with. So I wanted to let you know that. And I put the information in the chat.
Debbie, thank you so much for sharing that. We had a question from Kate. Are all Hope Centers in Gooding and Twin Falls?
So the residential center is in Gooding, and we help people from anywhere in the state get to our location. Our social workers will go out and drive them. We have other people that can get them here. We've flown them in. So they're all doing residential treatment in our Gooding Center. And then for the outpatient, they go back to wherever their primary location is. Some people need to relocate because they weren't in a safe, sober, supported environment, but we will follow them back and connect them wherever they need to be for that, back to their physical health, their mental health care, their continued addiction treatment. Dr. Reed Lofgren is our internal medicine and addictionologist, medical director. So he works with many of you and supports them on their MAT services, establishing that or maintaining that when they're here. So.
Thank you, Debbie. What a great resource. This has been a really great resource heavy session today. So thank you. If you guys have any questions for Cora or for Debbie or Connie, would love for you guys to ask them.
I'm so sorry, my computer kicked me off. Did you ask me a question?
Oh, you're all set, Connie. No worries.
Okay.
Well, if there's no questions, I'm going to turn it over to my panelists, and I am going to ask my panelists to just one clinical pearl takeaway. What are your biggest takeaways from today's session? And we'll go in this order. Let's do Lucy, Jake, Brenda, Eli, and Jenny.
Thanks, Shannon. Wonderful presentations, and thank you for sharing all the resources, everyone. One of the things that I think is really important to reconfirm that we heard today in our first presentation is the importance of encouraging breastfeeding and the safety with using methadone and buprenorphine during pregnancy in most cases, and encouraging patients to breastfeed if that's what they want to do. I think a lot of people are reluctant or nervous about the prospect of breastfeeding their baby while taking medication. But just to be clear, just like we encourage women to stay on treatment during pregnancy, we also encourage women to stay on treatment and breastfeed if they want to on those medications.
I think that my thing that I would reiterate from the talk is the fact that when we treat any condition really, but anything that is complex like pregnancy and substance use disorders, that Dr. Daly mentioned that it's a team approach. And I think that that's incredibly key, really, for any substance use disorder treatment, but in pregnancy especially, that I think reaching out to any provider who's involved in the care is not showing that you don't have all the answers and that you aren't doing your job. It's actually showing that you don't have all the answers and you're not supposed to have all the answers. And if anybody thinks they have all the answers, that's more dangerous than the people that recognize that, oh, I need help from other specialists. So I think that's something really important to reiterate, is that even though it can take extra time to kind of coordinate care, um, it's incredibly important to the care of substance use disorder patients, particularly in pregnancy.
Thanks, Jake. I think I would just second what Lucy and Jake said. Dr. Daly's presentation covered a lot of amazing information, and I don't know that there's anything I could add, but I think too, making sure we're coordinating together, especially with our pregnant women, making sure that we're all on the same page, doing the same thing and supporting them in the best way possible.
Thank you, Brenda. And Eli, are you available? I don't know if he had to step away. Oh, there he is.
Yes, I'm still here. I just changed some cases, but yeah, I don't really have much to add because I think my expertise doesn't really follow the same thing. Yeah, I enjoyed the presentation, and it's nice to know where the resources are for the patient.
Thanks, Eli. And Jenny, we'll close it up with you.
Yeah, I would echo, I think, what Brenda and Dr. Harris said as well. Just the importance of continuing therapy throughout pregnancy and the possibility that and the likelihood that they may need a dose increase, not only physiologically throughout pregnancy, but also just, pregnancy is a stressful time. And I think it's important to emphasize to patients that there's not like shame in increase, maybe needing a dose increase. And I like the point, like reemphasizing that being on a higher dose does not correlate with worse neonatal abstinence syndrome, and like reemphasizing that they're doing the best thing for their baby by being engaged in treatment. And I love what he said too about like just the collaborative approach and, involving the whole team and caring for the patient and just, cheering her along.
Thanks so much, guys. One last call for any questions before we close out today.
I actually have a question for Dr. Daly, if he is still on, that I thought of afterwards. And this was not the focus of the talk, but I remember in medical school when I was doing my OB rotation that one of the MFM docs that I worked with said that it's amazing how the two most dangerous drugs or common dangerous drugs on the fetus are alcohol and tobacco, and those are the legal drugs that we have out there. And of course, we don't. Pregnant patients who are drinking usually get a lot of attention, but I feel like smoking is kind of the substance use disorder that we don't address much. Is there anything in particular being done or that we can offer besides nicotine replacement that is specific to pregnancy, or your thoughts on that at all?
Yeah, so that's a great question, and I would be happy to do a topic on that. I think as a country, we've done a really, really nice job at emphasizing all of the dangers of alcohol use in pregnancy, right? All of those fetal alcohol syndrome outcomes are, for whatever reason, fresh on the mind of everyone who gets pregnant. I wish we could do the same with things like fentanyl, where we could say, hey, look, there are some really, really big risks to this, but neither here nor there on that one, I suppose. Nicotine, yeah. So treatment, just briefly, what I tend to recommend for my patients, nicotine replacement therapy, absolutely safe. Probably the same thing you're counseling your patients on, where a lot of times I'll use combination dosage. So they'll use a patch for kind of a basal rate, and then nicotine gum over the top of it, making sure, of course, we're counseling them on the chew and park method and all of that stuff that we know as far as NRT goes. I don't use Chantix for pregnant patients. There's really not good data on that. But I will use Wellbutrin. I've used that before at the same dosages, starting them out on 150 in the morning and then going up to 150 BID for those patients. And I've had fairly decent results with that. They don't do pregnancy categories on medications anymore, but when they were, bupropion is category B. So the vast majority of the medications I'm using in pregnancy fall into category C. Just we don't have any good data that says safe or dangerous. Category B being most likely safe, but we don't have definitive studies. And that's exactly what I tell my patients is, hey, we don't have definitive studies on this, but we do have studies that show risk of preterm delivery and fetal growth restriction with continued nicotine use. So getting you onto something that is safer, either nicotine replacement therapy with the intention to taper, or utilizing Wellbutrin, especially if the patient has kind of a co-occurring depressive disorder, I find works well for those patients. I had another thought on that, but I think it just left me. Yeah, so those are the ones that I would move towards.
Thank you.
Yeah, and just as a final plug, sorry, I didn't say this earlier, but if you have patients that you need consults on, I'm here. I'm always happy to help with them. I don't know if my email's in there or not, but my email can be sent out. I'm absolutely happy to help, and here in Idaho, trying to help.
If we don't have it, I'd really love to have contact information, just because I know we have pregnant women coming through fairly regularly, and a couple that have had some negative experiences that could use an OB that would understand and support them and not make them feel judged or whatever. So, yeah. And know that we're also here. If you're in Nampa, we're in Nampa, Boise, Pocatello. So know if we ever have any mutual patients, please feel free to reach out to us. We love to work on coordinating care for all of our patients.
Awesome, thank you. Yeah, it looks like my email just got sent out in the chat. I'm happy to field any of those.
I will also go ahead and put your email address on the overview page of our website. So if you would like to see it, it will be there for you guys. Thank you for making that a resource for everybody. Okay, so we are going to close out for today. Thank you guys all for being here. We're going to be back again in 3 weeks in November on November 13th. That's a Thursday from 12:15 to 1:15. We are going to be starting part 1 of 2 talking about fentanyl. So the first session is going to be on detoxification of fentanyl versus opioids. And then our next session, the last one of the year in December, is going to be talking about treating OUD in the fentanyl era. So we hope that you guys will join us for those. Again, next session is Thursday, November 13th. Make sure to complete your survey if you're looking to claim credit. Thanks, everybody. Have a great rest of your day.